National implementation research in the breakout session earlier. I'll get to say things like distinguished panel. And it is a real pleasure to introduce them because I know one of them really well and am working with one of them now in fun and interesting ways. So first I want to introduce Laura Louison. Laura is an associate director, I'm going to have to use my notes here, of resource development at NERN. And Laura has worked on a breadth of public health and implementation support projects in home visiting, maternal and child health. Together we worked on early childhood work. And fun fact about Laura, and I guess myself, is that we started at NERN on the very same day. And her career has seen a meteoric rise. And mine just kind of, you know, like apron strings. But she is a great colleague. Another fun fact, she knows pretty much everyone in every system in the state. So if you want to know a way in, talk with Laura. But she is going to talk to us today about assessing need and context in a very applied and practical way. Dr. Paul Lanier is a professor here at the School of Social Work, who also has a lot of experience with home visiting and evidence-based practice. And in his bio, I noted his interest in working with families of young children, but particularly fathers. And I know in my work in general, we're always interested in working with fathers, but they rarely actually get to the table or are supported to get there in ways that they want to be there. So I think that's an interesting fact. And Paul hails from Surrey County, where my mother was Miss Pilot Mountain in 1964. So, I don't have many fun facts about myself, but I am the core lead of the evidence-based decision-making core of the National MCH Workforce Development Center next door at the School of Public Health, through which I work with state MCH programs to both identify, introduce, or select, introduce, and support evidence-based programs across a range of family, maternal health, and child issues. And so it's really nice to be here in a place where so many different perspectives are present and so many different issues and needs. So thank you for being here. And with that, I want to tell you briefly what we're going to talk about today. We're going to define contextual fit and strategies for improving it. We're going to support the assessment. The results we intend to achieve is to support the assessment of population needs and contextual fit of programs, possible programs and practices. And we're going to look at the hexagon tool, which I think was referenced earlier. If it wasn't, it'll be referenced shortly, for supporting the selection of good fit interventions and practices. And we're going to use both some didactic elements, but also a case study to talk through and have you all think about what it would look like to do this work with the case that Paul will tee up for us. And we're going to weave some equity thinking and reflection through that as well. So you're about to have your minds blown. And with that, no pressure, Paul, I'll hand it off.
Great. Thanks, everybody. So, interesting fact, Oscar, my mother was also Miss Pilot Mountain, 1966. So no, I'm just kidding. We have some talk now. How about that? No, just kidding. That would have been really interesting, though. Okay, so what we decided to do is try to ground this discussion about context and fit in a case example to try to make it as relevant as possible. This is a fictional case study, but it could probably be pretty realistic and maybe seems like some things you're dealing with in your work today. So I've got some good news and maybe some bad news. Your organization has been funded to explore the implementation of evidence-supported interventions to reduce infant mortality in North Carolina. So highlighting the exploring, so if we think about the different phases of implementation, we're at the exploration phase, right? So we're thinking about which communities we'd want to serve, where, how, what kind of interventions, right? So this is going to lead into how we think about the context and the fit. So that's the good news. Someone's investing in reducing infant mortality. Bad news, unfortunately, your funding can only support 3 local sites. Does this sound familiar, potentially? Yep, right. So there's never enough funding. We're working with scarce resources. So this is often the challenge for implementation practitioners, is thinking about how to use the funds most wisely. So that's a lot of what's going on when we think about context and fit. So we've got two key questions maybe, and so we'll get into some more of the information Laura and Oscar will present, and we're going to come back to these questions at the end and maybe co-create some solutions together and think about what strategies may have worked in your practice that we could bring to this question, okay? So what areas of the state have the greatest need to reduce infant mortality, right? So this is one of the things your funder has tasked you to come up with. How are we going to define need, and how are we going to locate the highest need? What factors in the local context will impact contextual fit of the intervention, right? So we want to have a great fit between the intervention that is selected and that local site, okay? That makes sense? So these are the questions. Let's carry that in our head throughout the rest of this talk. A bit of context. So maybe the first thing you do, your reaction maybe to take North Carolina and say, well, which counties in the state have the highest rates of infant mortality? Right, and that's a totally acceptable kind of first reaction, right? So we've got some places out in the eastern part of the state that tend to have higher rates of infant mortality, right? So maybe we just pick those counties and we just go from there. So thinking about what would be the drawbacks about going with that more simplistic approach. We kind of from the outside just look at a map and say, we're going to pick these counties and go with it. Another thing we want to carry in our head is the fact of racial disparities in infant mortality in North Carolina. So we bring that knowledge to the table. Maybe the RFA that we responded to said nothing about race equity or racial disparities, but coming in, we know that North Carolina has one of the worst disparities in the country with infant mortality. So overall, about 7 per 1,000, with the rate of Black infant mortality over twice that of white and Hispanic families. Okay, so understanding, bringing that race equity lens to the work of implementation science is going to be a key role of us as the implementation practitioner as we approach this problem. Another thing you may do is think about the theory of change or the social determinants of how you get to infant mortality. So this is something you can pull from a national source. So AmChip and March of Dimes has said, well, here's infant mortality, and we're going to walk back and try to understand this causal diagram of how we get to infant mortality. So again, what your lens is for explaining that causal effect is going to be important when you're looking at interventions, and how local communities understand the causal mechanisms will be very important as you work with them to select interventions. So thinking about a theory of change for where the intervention is that you're thinking about, maybe it's early home visiting services, for example, with the social or health problem, how that's understood in that local context, right? So there's lots of things in these menus that you could address, whether it's healthcare access, prenatal care, lots of things. So understanding what the story is, the narrative about those causal pathways at the local context, and how that matches with interventions that you would maybe propose selecting with that community. Okay, so we'll keep that in your mind, and we'll come back in the Q&A and discuss some more about how you would approach this problem in North Carolina, given what you're about to learn from Laura and Oscar.
I love this. It's like a cliffhanger to start with. I also really like this podium because unlike in other places, I don't have to stand on a suitcase in order to be seen over it. So I am guessing that the scenario Paul just laid out feels very familiar to many of you. Regardless of what field you work in, social work or public health, juvenile justice, or child welfare, all implementation efforts have somewhere within them a genesis story that starts an exploration, where an organization or a system, a group of people is identifying a problem and then attempting to match that by selecting a solution they believe can meet that problem. And in health and human services, in implementation as usual, as Byron talked about this morning, we almost always do that in the context of a needs assessment. I'm guessing if you're a student, you've spent a lot of time talking about needs assessments. I know that I have done a lot of needs assessments in my work and was trained on how to do them. And so I imagine that you are picturing in your head the same kind of thing that I learned, which is that a needs assessment is a systematic review of gaps, right? It's an attempt to quantify, to measure the discrepancy between our current state for a population or a community and our desired state. And then we use that analysis in order to inform our selection of something, one of those P's that Byron mentioned this morning, a program or a practice, that we think has a good chance of fixing the problem. Most of the time when we do needs assessments in our work, we are not operating in optimal conditions, right? We are responding to an RFA that has a 28-day turnaround time, minus maybe 3 days to get it to your business office. We end up like this guy in our picture with a lot of coffee and some Excel files alone. Frequently, we do needs assessments within the silos of our organizations. So we do them by ourselves, we do them within our division, but we don't have the time, sometimes we don't have the resources to reach out to other stakeholders who are implicated in what we're trying to address. Whether those are family members or community members, or those are other practitioners who might share this work. We focus on the numbers. There's this great quote about how health statistics are people with the tears wiped off. And that feels really relevant to me in the context of the maps that Paul showed, right? Those are real babies. Those are real losses. But when we do needs assessment, we have to think big picture, and we put things in a grant and we move on. Over time in our work, I think in our work at the National Implementation Research Network, as well as in the work of other colleagues in implementation science, we've come to feel that this approach to implementation as usual and needs assessment as usual is limiting us. It is, I think, getting in the way of understanding both the problems and the solutions. So we're treating this as an X equals Y problem, right? We're gonna plug an evidence-based practice in here and that's gonna fix things. And you all know that that's not how this works, right? This isn't an algebraic equation. This is a complex system with many things moving, often in opposition to each other. And so I think one of the challenges with approaching needs assessment in this traditional way is that we're limited in the story that we can tell and understand about both the problem and the solution. There's a Nigerian author who I adore, Chimamanda Ngozi Adichie. I think I said her name correctly, but she has this now very famous TED Talk where she talks about the danger of a single story, which is not that the single story is inaccurate, but that it is incomplete. And that's how I've come to feel about traditional needs assessment in the context of implementation, which is not that those maps are wrong, right? Those tell a stark and true story, but they don't tell the whole story. And they don't help us understand what might be the best fit for addressing some of those challenges. We also know that, as I think both Byron and Allison noted this morning, that even though we're investing a lot of money in evidence, in using evidence in practice, particularly under the previous administration, we are not seeing the results that we want. And while the uptake of evidence in communities is very high, the sustainability of that evidence is not. And so there's some work that indicates that really only 1 in 4, maybe 1 in 3 interventions that are implemented in communities are sustained over time. They make it past initial implementation. So that means, 1, that our investments are not getting us what we want, which is a hard pill to swallow in an increasingly competitive funding environment with limited resources. But it also really means that the people we care about, the people behind the health statistics, are not benefiting. And so, I think there are lots of reasons that this is the case, right? We are at a 2-day institute to talk about the reasons why this is the case. We think that one of those reasons, part of this problem, is the fact that we aren't doing a good job of understanding the problem and the solution and thinking about what we call contextual fit, which is that match between the evidence and the environment. It's that simple story pushing back on us, right? This isn't an X equals Y. This is a sort of a canvas with many colors and moving parts that we have to figure out how do we weave into this to find the best possible fit, given what we know about both the problem and the solution. So the relationship between the evidence, the program that we implement, and the context where it will be implemented, we think is really one of the key factors in success. When we don't pay good attention to that, I think there's a high likelihood of misalignment that can set something up for failure. And sometimes we can make something happen for a short period of time, but we can't sustain it for the long haul. So we see this a lot in work in rural communities, where there are programs or practices that were developed in urban or academic environments, and then we attempt to roll them out in places where there may not be a lot of licensed clinical social workers running around, or the program isn't a good fit for what the community perceives as valuable, and we wonder why it didn't work. And in many cases, I think it's that question of contextual fit. And some work that Oscar and I and some others in the room were part of in Eastern North Carolina, I think we have a really nice example of this, where there were challenges identified that were related to children's school readiness. And so there was a desire to improve the quality of early care and education that was available for kids in those communities. That was a great strategy, right? There's good evidence behind improving the quality of care for young kids. Except that in some of these counties, there was no licensed childcare, or there was only one licensed childcare or pre-K program. And so we had this mismatch between the evidence and the context that we were going to implement it in a really fundamental way. I think we've come to believe that successful match with contextual fit increases the likelihood of sustainability over time, and that programs that are a good fit with communities are more likely to keep going. There was some discussion earlier this morning about these questions of equity and what implementation science's role is in promoting equity, in perhaps provoking conversations that help us to dig deeper and ask why. And I think one of the reasons that we often don't take the time or ask the questions that are necessary to assess contextual fit is because we do not have strong histories of including the people who will be impacted by our potential solutions in the conversation. So this is rarely done. And frankly, when it's done, it's not done very well. And I think that traditional needs assessments start with numbers, not people, and it's messy and complicated work to include them, and work that often doesn't neatly fit within a timeline for an RFA or within an organization's ways of doing work as usual. So if we want evidence to be sustained in communities and to see the investments we make in programs result in outcomes, we need to tackle assessment differently. And so when we think about the practice of implementation, one of the key skills that implementation specialists need to be able to have is that ability to assess need and context in a comprehensive way. And so Allison spoke this morning about the implementation specialist competencies that we've developed at NERN. And under the category of assessing need and context, we really are talking about this idea of working with stakeholders to understand population and community needs and the extent to which possible interventions can meet identified needs. Supporting contextual fit between interventions and the local service settings, bringing stakeholders together, all of that is messy and really interesting work. And as a social worker, I think that's what we do, right? So there was a discussion this morning about how social workers have this skill to look at issues and need in the context of environments, and I think this is that skill. So we know a little bit about best practices for doing this well, strategies that you can use if you're interested in assessing need and context. And I'm going to talk briefly about those, and then I'm going to highlight a tool that NERN has had for a while that we've recently done some revisions on that can be one aspect of how you do this in your own work. And we know that tools aren't the be-all and end-all. You have to implement their use. But we think this is a really helpful strategy for promoting the kinds of conversations that are necessary around this kind of assessment. So these best practices probably don't surprise you, right? Just because we're interested in a more holistic assessment of need and context doesn't mean we're not interested in data. In fact, I think what we're interested in is more data, and lots of it, both big D, the quantitative kinds of maps that Paul showed earlier, as well as the little d, the conversations that we have with community members and with practitioners, the focus groups, the kinds of responses we're seeing to the interventions we already implement in communities. We also know that a best practice around assessment is that it be team-based, and that is very challenging in the context of limited time and resources. Often organizations have somebody who writes the grants, Or the somebody who writes the grants is also the somebody who implements the programs often, and they are really rushed for time. And we believe that the team-based approach is necessary because it allows us to ensure that different perspectives are coming to the table around this. And those different perspectives are necessary for truly being able to assess contextual fit. So you might have a team that doesn't just include a grant writer and a practitioner, but also somebody who's a foster care social worker who's actually working with families and looking for placements at 4 o'clock on a Sunday afternoon, as well as a family whose children have been in care, or a community member who's an advocate. And developing a team around these kinds of assessments really enables them to be more holistically responsive to the needs of the community, as well as ensure that we're achieving the goal of having our work be stakeholder centered, not with participation from stakeholders, but stakeholder centered, really understanding the story behind the simple story. So one approach to doing that systematically, that kind of participatory assessment, is the hexagon tool that you see before you. It's named very creatively. You will notice that it is not a triangle or a pentagon, but is in fact a hexagon. The hexagon is a tool that can be used by public agencies, by nonprofits, communities, to help make informed choices about evidence, to both assess the need in a community and identify some key factors in the relationship between that need and the organization and the possible program or intervention that you're proposing to implement. So you all, I believe, have a copy of the newly revised hexagon tool in your folders. This is a tool that was originally developed by colleagues at the University of Maryland School of Medicine and then was adapted by NERN. And we're really excited to be using this institute as an opportunity to showcase this new revision that you have in your hands, and a number of improvements that we've made to this tool in collaboration with our colleagues at the Annie Casey Foundation. So you'll notice that the hexagon is a tool that is, unsurprisingly, divided into 6 domains. So these are 6 categories of factors that we think are important to consider when selecting a program or practice to implement. They're divided, they're color-coded in the version that you have between you. And we've done this division now because it allows us to really make the experience of the service agency and the population who will be impacted, it allows us to make that more prominent in our assessments. So you'll see that 3 of the domains in the hexagon are green, and they relate to the program or practice that's going to be implemented. So questions around what kind of evidence the program or practice has and how strong it is. Questions around what kind of support is available to implement this program or practice. Is there training? Is there a curriculum? And how usable is this? How well can this actually be done in the real world? A lot of times when we're thinking about evidence-based practices, we're chasing that bright, new, shiny object that we heard about it at a conference, much like this one. And we often stop there. Like, this sounds really exciting. Other people are having success with this. It's got some evidence. Let's go. And the other 3 domains in the hexagon remind us of the need to then think about that evidence in context and assess the environment that we're proposing to implement this within, and think about that relationship, that reciprocal relationship between the intervention and the place we're going to do that in. So we need to think first about need. What kind of needs are going to be are of concern in my community, and how might this address them? How well does this fit in my community and align with my community's historical values or questions, our context? And then what kind of capacity do we have to do this work now? What kind of staff do we have? If we're an agency doing this kind of thing, what would it mean to be shifting our course and trying out something new? So thinking about all 6 of those domains, you'll see in your discussion guide, and there'll be a breakout session after this if you're interested in talking more about it, that we have structured a process of people being able to systematically evaluate those 6 domains and then be able to rate them. In our work with our colleagues at Annie Casey, we've also been really excited to be thinking about what it might mean to bring a race, equity, and inclusion lens to this tool. And what it would be what what it would mean to be thinking about that in each of these domains. So not just to be asking what is the need in our community, but to push further and to ask sort of those next levels of why. So why is that the case? What does the disaggregated data show us? What is the community we're talking about? What is their perception of their need? And how do they think about this challenge within their own context? And so we're really excited to have that, have had that feedback, and also to be able to incorporate that into our discussion guide now. Another thing I want to say, I think that relates to some of Byron's comments this morning, is that this is a tool that's typically used in exploration, right? In Paul's case study, he talks about this great funding opportunity and the chance to pick a couple places. And often that's when we're thinking about these kinds of selections. However, most of us in the room have been involved in some kind of implementation effort gone wrong. And in those kind of efforts, it's just as important to think about what the barriers are, as Byron was mentioning this morning. And this is a tool that can also help do that. So if we are implementing some new program that we were really excited about and not getting the results that we thought, maybe it's a question of fit. And this tool can help us systematically look at those barriers as well. I want to make sure that we have enough time to come back to both the case study as well as some ideas around how you might use this tool in your own practice. So I'm just going to highlight two things related to this. So one is that we touched briefly on this question of need, which is thinking about what the need is within a community. But I also want to make sure that we talk about fit, which is one of our domains here. So in your discussion guide, you'll see that some important questions when it comes to fit relate to how the new thing, your new shiny object, is going to align with the other multiple moving systems in your landscape. So asking questions around how does this align with our community, with regional and state priorities? How does this fit with family and community values and culture and history? So if you are thinking about adopting a comprehensive sex education curriculum in your community and you have a history of primarily doing abstinence only, this is a place where you would want to note that. Thinking about how this aligns with other things an organization is doing. So often this is prompting us to ask questions around whether or not we're just piling on more rather than selectively choosing something new to add. As well as thinking about how this aligns with our organizational structure. So for an agency that has typically done primarily health education, this gives us an opportunity to think about, if an intervention is stretching us to now be doing different kinds of interventions or behavioral health work, what that means. So that's sort of a deep dive into one of the domains, but I encourage you to look at the guide in your folder and think about other questions you might ask related to this or the other categories. And I want to make sure that we know the tool, just like an intervention isn't a magic bullet, the hexagon isn't a magic bullet either. So using it isn't going to ensure that you have perfect contextual fit. In fact, in many cases, that's probably always not really possible. And it's also not going to make sure that you achieve equitable outcomes or reduce all disparities in the population you're working with. So just as it's important to think about how we implement evidence-based practices, it's really important to think about how we would use a tool like this effectively. And I'm going to transition to Oscar, who's going to talk a little bit about that as well as some examples I think you've seen in your work.
Speaking of implementation projects gone wrong, there's a high risk of this right now. So seriously, I wanted to highlight for you, I wanted to zoom out perhaps a little bit and think about contextual fit as more, bring in an equity lens and think about the process around which assessing or thinking about contextual fit might work. And I wanted to reference these two tools that you see here on the screen. One, on your left, the Foundational Practices for Health Equity is a very broad organizational or systemic way of thinking about the capacity and the awareness and understanding of equity in your system or organization. It's a big honking tool that's going to take a lot of work and raise a lot of issues. It is available. The link is in the PowerPoint, but it was developed out of one of the coins, which is I'll tell you what a coin is. It's a collaborative improvement and innovation network focused on infant and maternal mortality. That's very broad and can tell you about your system, whereas the tool on the right was actually developed here in North Carolina, and a shout out to our DPH colleagues who are here who supported this, and I'll give some examples of how it's used. It's much more focused on understanding the potential contributions to equity or inequity that a program or policy might have. So together these nicely complement kind of broad and focused. And so the context of, and that's available on the NC Child website, and that link is also in the PowerPoint. But just to frame or contextualize my comments. So what I thought I would do is hit on 1 point per slide, but I put others up there, and I was reflecting on, right, so the tool's not magic in and of itself. You can use it inequitably. You can use it to promote inequity if you want to, intentionally or not. So what would it take? What would you want to be thinking about if you were really trying to introduce the tool in an equitable way? And so before, I wanted to highlight the text in blue there, which is really getting ahead of the curve. And you don't always have that opportunity, but no program happens in a vacuum. And so I'm going to use the Title V, it's a state level maternal and child health funding stream that is ongoing every year. And to my knowledge, no state ever is defunded. So there are opportunities in there to begin engaging proactively with communities that are experiencing inequities or disparities and have them at the table before the grant opportunity hits your email or that you discover that. And when I was listening to Allison earlier, I was thinking about addressing power differentials. You could begin to structurally address power differentials by creating a table that isn't about an opportunity that you have to respond to in 20 days, because that's not the time to address power differentials. You could really begin to introduce co-learning into that environment, which it may feel a little weird because it could be a little open-ended, but when the opportunity strikes, you'll be much more ready. And those difficult discussions about inequities that we're going to have in a moment are probably going to have a better landing space if folks have had a little bit of time to be ready to have that discussion. And that great comment earlier about underserved, high need communities. I think if we're preparing this environment when the opportunity strikes, then we might actually at least reduce the risk of contributing to inequity by having to rush to the best decision we can make in 28 days. So now we're in the assessment. Whatever we've done before, we're busy doing our needs assessment and we're thinking about contextual fit. And I want to speak to root causes here, and I actually want to adapt that bullet. As I reflected later, this is not the time, at least in looking at contextual fit, it's not the time to identify root causes. You've hopefully done that already, and you've been thinking beyond the immediate service need to what's the context for that service need. Clearly, there's probably some need for some home visiting in this community. Why is there need for home visiting, right? Is it an economic issue? Or what are those root causes, just to give that simple example? So here, I'd rather have that bullet say, if I could go back and edit it, really make sure that you're linking back to your root causes and thinking about the relationship. Now, when you get an opportunity to do home visiting, they don't say, by the way, if you want to address employment, give us a call, we'll talk about it, right? You're probably going to have to do home visiting, but you may make choices that are different with an understanding of how employment plays a role in your community. And that's, again, way too simplistic, but just to make sure you're doing that link back to good needs assessment work you've done around root causes. And then in the hexagon tool, there's discussion of contextual adaptations. And some of those are going to be really relevant, and you may not know unless you engage with the developer or the purveyor to find out. Have you ever done it in a community that looks like the ones we chose? Because I'm not seeing that. And you may find out they have, and they've got a lot to tell you, but that may not be in the glossy brochure or on the website. You may also find out that they never have. And so you may still go forward, but you want to go forward with that knowledge. And finally, what happens after assessment? This is where we really want to be paying attention to the unintended consequences And one that just came to mind for me is all that analysis around fit that we did it come true? Does this really fit? We probably still made some assumptions, had some hypotheses, and we may find out that this is not the fit we thought it was. And nobody wants to arrive there, but we sometimes do, and we want to find out as soon as we can and make the adjustments, even if it means reversing course. So I just wanted to again, contextualize both the broad needs assessment and the more focused contextual fit that fits into the broader needs assessment, and have us thinking about process and our methods. And so with that, I'm going to hand back to Paul, and who's going to tee off a Q&A.
Okay, so coming back to the case study we talked about, this is your opportunity to participate and jump in, and we can, again, co-learn from each other, from lots of the mistakes and victories we've had in the past. Okay, so again, here is kind of the setup, right? We want to explore implementation of evidence-supported interventions to reduce infant mortality in North Carolina. I'm gonna walk over, grab the mic, and play Oprah, and walk around and hear what ideas come to mind, things that don't work, things that would work, maybe some new ideas that are coming to mind about how you would approach this problem differently. All right, we're mic'd up. Okay, Sarah's got one over there too. So again, no wrong. And again, we want bonus points if you can address this from, again, thinking about a race equity lens as well. How would you come to needs assessment maybe differently, given the context of racial disparities and infant mortality in North Carolina?
Well, one thing you would have to ask about is what is access to care like for those counties?
Great, so thinking about access to care would be an important thing. And maybe there are different ways you could figure out the question of access to care, right? There's some statistics or data you could look at, but going and talking to people about their experiences with access to care versus just looking at maybe some numbers, right? Yep. Great, other thoughts? Thank you.
So one thing that I was curious about, and you really teed this up nicely, is if I were to meet with families whose infant had died, what's the story they would tell me about the experience that led to their child's death? And do any of my evidence-supported interventions map onto those stories at all?
Great point. This one maybe feels a little bit uncomfortable, but Hyde County, which is one of the counties out there, I think it was 10 or 11 deaths we're talking about. So this is a feasible proposition to say, we're thinking about going to this county. Let's see, to the extent people are comfortable with it, sharing their stories with us. Great, thank you.
I think first, if I'm really concerned about racial equity, I need to make sure that the people on my board, the people that I'm hiring, the people that are making decisions are also people that have a personal lens on racial equity as well.
I see our Division of Public Health people being very quiet over there. So just.
I don't have the cool mic, but this one still works. Anyone else? Thank you.
I think the exploration of the other community, both formal and informal resources that are collaborating and aware of infant mortality and what they bring to it, either from having or not having that equity lens, and how you can bring them in.
So what are the other organizations maybe in those specific areas, understanding what they're doing, the extent to which race equity and inclusion issues are kind of at the forefront of the work that they're doing, bringing them maybe a way to engage them in this process as well. Yeah, great.
I have the exciting mic now. So I think what I like about this case study is that it talks about being funded to explore, which is often not a luxury we have, right? Typically, or often, our funding announcements are to do. But the exploration part of this is pretty exciting. So I could imagine an opportunity for picking potentially 3 very high need counties that are on paper as having high rates, but bringing them together for that exploration conversation and using funding to support that as opposed to supporting implementation. Now, that's a different conversation to have in a community, and it can feel really hard to do that, particularly if a community sees strong need but doesn't feel like they're getting something tangible when they want to address it immediately. But I think the exploration conversation, if there can be funding to do that, that could have real long-term impacts. I really want to throw this to someone now, if there's somebody who'd like to catch. Okay. I don't want to hit Kurt.
Well, in thinking about exploring, I would like to explore areas or states or communities where the equity gap has closed, and what has happened there that has allowed that to happen. And so that's something that I would, kind of spend my energy around.
Hey, I'm gonna throw this one. Just kidding.
I had the same kind of thought, only it was kind of the opposite. You were looking at, what has worked. I would also ask, reducing infant mortality has been around for a long time. What hasn't worked? Why are we still having to work at this gap and infant mortality at all? And so I guess I would want to look back at what have we done and explore possible reasons for why what we've tried to do before has not been successful. And in that process, incorporate all the stakeholders who could give some input on that, and not just the usual, like either the researchers or the program implementers to think about it, but to incorporate a whole lot of perspectives on it.
I kind of wondered about the definition of need, I guess, and I'm also wondering about need in terms of balancing it with kind of the low-hanging fruit. I wondered if we need to consider need, but also what can we do to show improvement that could then be used to spread to other sites.
I think I would add that the importance of really understanding what advocacy groups beyond the organization are the ones that those populations go to. For example, in the immigrant population, faith-based organizations are really essential, but many times there's a huge gap between mental health organizations and faith-based organizations, whereas people gravitate in faith-based organizations. So are we including everyone in the conversation who are already providing that advocacy?
Want to hold the again, but no, I had a thought that what I would want to do also is really take a look at near misses or programs that are kind of there but not quite, and really try to understand what kind of behavioral, economic, or exploration of different kind of dissecting the intervention, and are there reasons why taking Black infant mortality, that perhaps the intervention was designed for a white community or a different community or just community as a whole, just people, and really trying to take a look and dissect, and are there ways to reiterate what is there and bring it kind of cross the chasm, so not throwing the baby out with the bathwater. Oh well, but but yeah, really trying to explore the intervention a little more.
I think it was not necessarily a rhetorical question about need, but Laura or Oscar, I wonder if we want to just quickly go back to the need slide as far as in the hexagon tool, and not to put one of you on the spot, could maybe just say a little bit more about what's in that bucket as far as assessing need and maybe how you've applied it, if you have an example ready.
And I'm sorry, missed the handoff. Yeah, so when we think about need, we really want to think about an equitable problem definition, right? And so thinking about who the population is and what their needs are, and then really being able to drill down. And sometimes that's not always possible, but to the extent that we can, to look at how do we disaggregate that by language, by socioeconomic status, by race and ethnicity. And then I think the other sort of the reciprocal part of that is then how does that community perceive their need, right? We can sit here in North Carolina and Raleigh and run statistics and be able to say, you know, we've decided this is what we're doing in our state, but it's a totally different thing to be able to go to a Hyde County and say, so let's sit and talk. How do you see this need? And so I think those two pieces are really what makes the use of the hexagon tool different than a traditional approach to needs assessment and selecting an evidence-based practice.
I'm kind of curious how we avoid having data also be a barrier in terms of disaggregating something to the point where then funders or administrators say, well, you have such a small number in these particular categories. I don't know that you can really draw conclusions in essence from this particular data set. You know, we need more time to study things.
Yeah, that's a great point. So small, I would say, stop. Okay. Yeah, so what speaks perfectly to this idea of, you know, having some mixed methods and some qualitative to go in along with the quantitative data that you have. That may be one solution. Probably won't answer all of it. Okay, so time's up for this session. I'd like to thank Laura and Oscar for the presentation, and maybe Sarah's going to say some things about.
I'm using the fun box because I want to try to get it to the balcony by the close of this summit tomorrow, maybe. So I would like to thank Oscar, Laura, and Paul for their presentation.